Well, our next speaker is Ms. Suzanne Geerts.
Right.
And she received her Master's of Science in Clinical Nutrition from UAB, where she resides as a clinical assistant professor within the Department of Nutrition Sciences. Ms. Geerts has a standing appointment with the UAB Graduate School faculty and serves as a dietetic internship preceptor. She currently provides and oversees the delivery of clinical nutritional services to patients within UAB's Genetics Clinic, Rett Syndrome Clinic, Suzie Sparks Clinic for Developmental Disabilities. Her research and clinical interests are aimed at the discovery and needs of unique interventions designed to meet the nutritional needs of individuals with inherited and genetic disorders. Welcome, Ms. Geerts.
Thank you. I like the setup. I like the setup that Dr. Franklin had earlier. I thought that would work well for me. Thank you so much for inviting me to talk today. And as I was getting ready for lunch, I knew that I had a 2 o'clock appointment that I needed to run back for, but I thought I've got this covered. And as we were getting ready for lunch, I had a message that I know I was supposed to be there at 1. So I told them they just have to wait a little bit, and I'll get there as soon as I can. We're going to talk today about fostering positive mental health through nutrition intervention in the special needs environment. All of the children that I see fall in that bracket. It's kind of touchy. Right there, right? Okay, learning objectives really quickly. We're going to define the terms developmental disabilities in children with special health care needs. We're going to look at 6 common problems that we find in the special needs population in terms of nutrition evaluation and also treatment. And then we're also going to talk about 5 mental health problems that correlate with those nutrition problems. And last but not least, I have several case studies. But I really am going to run through these slides because I really want you to spend time with my friend, Miss Susan Lee. Susan's daughter, Alyssa Lee, has Rett syndrome. How many of you have heard about Rett syndrome before? Okay, very good. A lot of times I'd ask and people wouldn't know anything about it. So this is nice that we have some people that are aware of it. I'm a very practical person, and in working with special needs and in doing this presentation, there's some things that I really want you to remember, even if I don't say them. First of all, there's a spectrum of what you see. Anytime that you have a diagnosis, you really need to look beyond that diagnosis and look at the individual and make sure that you're doing your best to meet their individual needs. Also, there can be more than one genetic disorder which is there. I had a Rett parent tell me one time, she called me on a Friday afternoon and she said, all my daughter wants to do is drink water. And I thought, ooh, that doesn't sound good. So I questioned her a little bit further and I said, I really need you to call the pediatrician's office and take her in and do a fasting blood sugar because we have to make sure she doesn't have diabetes. And the mother said, oh no, she can't have diabetes because she has Rett syndrome already. And there are multiple other incidences of that. There's a high degree of celiac disease with Down syndrome. In Down syndrome, you can see hypothyroid conditions. So there are many examples of that. So again, we have to be aware of that. Parents know their children very well. As you could tell yesterday by our parent panel, they often have studied in depth the treatments that are available. They know their child. So you need to learn to be a good listener, and also you need to be flexible sometimes with the plans that they already have and educate them when we need to make changes in those plans. In addition, a word that we've heard a lot of lately is creative. You need to be creative to be able to be an effective practitioner. Last but not least, working in this area is a complex medical field. It takes critical thinking skills, and sometimes you just have to think outside the box. A little bit about genetics. Our practice now is, genetics used to be this tiny office in Sparks. As Harriet Cloud shared with you yesterday, Sparks clinics opened in 1969. And genetics used to be this tiny office within Sparks clinics. But now it's grown to be this huge division all on its own. And so genetics is very important, and this is one of our basic tenets of genetics. One of the reasons why we see so much variability in individuals, as well as variability in their disease course, is because of the genetics. Remember, there are 3 billion base pairs in DNA, which code for the 20,000 genes in the human body. Also, we need to remember that mutations can come in different sizes. They can be deletions, duplications, splicing, many different things that we can see. And our geneticists, when they begin educating parents, always tell them we all carry mutations. If we were to go and look at all of our genome, we all carry mutations. Some are benign. Some of them are pathologic. Many of them are variants of unknown significance, VUs. They don't even know what they mean. So genetics is very important in our field today, and I'd highly recommend in your education path that you take some type of genetics class because it's very prominent in what we do today. Definitions: what's a developmental disability? A developmental disability is a severe chronic disability that is attributed to mental or physical impairment or a combination. Usually manifests before the age of 22, will continue indefinitely, and it usually results in a substantial functional limitations in 3 or more activities of daily living. And those can be limitations in self-care, receptive or expressive language, learning, mobility, self-direction, independent living, and also economic sufficiency. Who are the children with special health care needs? They are children with congenital or acquired conditions that affect physical, emotional, or cognitive growth and development, require more than the usual pediatric health care. Children with developmental disabilities or other chronic conditions, health-related problems are at risk for these conditions, and there are hundreds of examples. When we look at genetics, there are thousands of genetic disorders. There are hundreds of metabolic disorders. And so this list of examples can go on and on. Intellectual disability. Impairment in intellectual or adaptive functioning. It's usually identified by cognitive and adaptive testing by a trained professional. It's an IQ usually less than 70. And it's also the preferred term for mental retardation. About 15 years ago, there was a big campaign by many of the clients with IDD themselves to say, we don't want that term to be used anymore. We don't want to be taught retarded anymore. We want them to use this term. And they advocated for themselves, and they won. Size of the population. In the population from children aged 3 to 17. CDC in 2016 reported that 1 in 6 of all children have 1 or more developmental disability. 1 in 68 patients now have autism spectrum disorder. Part of the increasing numbers that we're seeing are because of one of the screeners tool, which is now used, which is called Learn the Signs, Act Early. About 1 in 110 Americans have autism spectrum disorder. So you may know someone who's on the autism spectrum disorder. In general, these numbers are increasing, and there are reasons for that. We now have expanded newborn screening. In the late 1960s, newborn screening consisted of screening for about 5 medical conditions and only 2 metabolic conditions. Back in 2005, new technology became available. And with expanded newborn screening, we now screen for about 8 medical conditions, hearing loss, and about 43 metabolic conditions. So a significant number, which we're picking up when the children are in the very first few weeks of life. Premature infants now are increasing in numbers. And over time, these children are sometimes sicker than they used to be. I happen to be the mother of 2 special needs children, and my first daughter was born at 27 weeks, and that was over 30 years ago. And I remember when they came into my room and they said, "She's just over 2 pounds, she'll probably make it." Well, as a new mother, you cry all the time anyway, and those were encouraging words from the physician who was very supportive of me. But I'll never forget, if she's over 2 pounds, she's probably going to make it. And now to put that in perspective today, the babies that are in the nurseries are tiny. They're not even half a pound, 3/4 pounders. So to think how tiny my little baby was, and to think that those babies are now surviving. But again, some of them do have long-term medical complications. So we are seeing an increasing number of those in our marketplace as special needs dietitians. And there are lots of screening initiatives out there lately. We heard some of the screening initiatives by our mental health professionals, as well as they have the, again, Learn the Signs, Act Early. There are a number of screening initiatives, so our numbers are increasing. Again, a little bit about genetics. We work with the genetics division. Genetic testing is expensive. It's usually done one step at a time to help with the expense. We now have whole genome sequencing, which they're looking and reading each base unit and seeing if there are patterns. They're coming up with new information in terms of new diagnosis for parents who or a child who may have not had one before, but also they're also coming up with a lot of variants of unknown significance, also known as VUS. But what they're doing is they're taking that information and it's being entered into a worldwide registry so that we have more information as it becomes available to us to use for diagnostic purposes. There's also precision medicine now, and this is an emerging approach to disease treatment which takes into account genes, the environment, and also your personal lifestyle. And so there's been a big push for precision medicine, especially at UAB, for about the last 4 years. And again, one thing that we've really seen with genetic testing is we get diagnosis much quicker than we used to. I started at Sparks at 2002. And I was hired to be the metabolic for the late Dr. Elaine Rutledge. I was hired to be her dietitian. And at the time, if we had a baby that had an abnormal newborn screen, she would evaluate the biochemical data that she saw, and she would give the baby a diagnosis. And often we would have to send off testing. And sometimes that testing would go to specialized centers, sometimes it'd go out of the country. So it wasn't uncommon for us not to have a diagnosis, a clear diagnosis on the baby for a month, 6 months, 8 months. It depends on where it had to go. Now if you have an abnormal newborn screen, you send off for that gene mutation. Babies who are sick have priority, and you will have a clear diagnosis, and whatever that implies, usually within 7 to 14 days. So much better medicine, much more accuracy in diagnosis. Okay, nutrition problems. There are books written about this. One thing I want to recognize is Harriet Cloud, who was with us yesterday. You really need to know Harriet. She has been an advocate for special needs nutrition for decades. She's still involved in the field. She's also been active in the academy. She's also been active in the state association. So hopefully if she'll come back tomorrow, tell her thank you, because she paved the way for us as young dietitians and nutritionists in the field that we are today. So again, there are many interpretations of this. I chose to use Bright Future's Nutrition. There is actually a book which was put out in 2011. It was put out by the Health Resources and Services Administration, HRSA, and the Maternal and Child Health Bureau. And it's called Bright Futures, and I really like this book, and it's an excellent introductory tool if you're starting to work in the area of pediatrics. It goes through different age groups, as well as it gives you risk assessments that you could do for different age groups and tools in the back. This is free to you if you'll go to Bright Futures at the American Academy of Pediatrics in total. So it's an excellent training tool and it's an excellent place to look up information. So they have a chapter on special needs. And so this is how they broke down the categories. It's much more detailed than this, but we're going through this today to stay within our time limit. Again, medications. Harriet did a wonderful job on medications yesterday. There can be a lot of alterations in GI function. Chronic constipation, delayed emptying, reflux issues, others. There can be appetite changes with abnormal feeding behaviors. Y'all are familiar with pica. And the children that we see at Sparks, many of the children come in for evaluation for autism spectrum disorder and also attention deficit hyperactive disorder. And so we see a lot of kids that have behavioral abnormalities. Pica is still alive and well. And so you need to make sure that you are screening for them eating abnormal objects. Carpet fibers, hair, paper, it's still there. Poor dental care is very rampant. It's very hard to find a special needs dentist. If you live in a rural area of Alabama, sometimes it's almost impossible to find someone to help with your child, and they need special care. An autistic child is not going to want to sit in a dental chair, have you in his mouth, have you putting things in his mouth. So they really have to have someone who knows how to handle those children to meet their needs the best. At the very bottom, I added social and family dynamics because as we've been talking about for the last day and a half, there are many things that happen in the family environment that we have to take into consideration as practitioners. A lot of the children that we see are in foster care, or they're in adoptive families. A lot of them are in blended families, so there are many issues that come with pediatrics. A little bit of how growth can be altered in the special needs populations. They can sometimes have limited growth potential, low muscle tone. Many of the children that I work with really sometimes are not able to stand, sometimes they're not able to sit. They can have gross delayed motor development. There's a greater potential if they're unable to walk for them to be overweight, so we have to be particularly vigilant. And then again, sometimes after their growth years, their growth velocity can change significantly. In addition to that, they can have very different energy needs. Their needs may be lower. Their basal needs may be lower. They may not move, so their activity level may be significantly lowered. And then also sometimes we don't have a reason. I had a young lady recently that was doing very well. She's completely grown, was completely tube-fed, everything was stable, and all of a sudden her weight was climbing. It was 54, it was 58, it was 62, it got to 70, the mother panicked, she called me. I really don't know why it changed. I think what happened is that she had had scoliosis surgery at an early age because her curvature was so bad. So we kind of thought she wasn't going to grow anymore, but I think she was telling us, I'm going into puberty whether you like it or not, and I'm growing whether you like it or not. So sometimes we don't have an answer for that. And it's really difficult to estimate their needs because I can use all the standard formulas that are out there, but really they are very much an estimate. And the best thing to do is to know what they're being fed and to have a good idea of what their calorie intake is, because sometimes the numbers don't match up. Okay, interestingly enough, puberty is different with children with special needs too. Sometimes when you're working with adolescents, you always need to look at what stage of puberty that they're in. But sometimes it can be delayed. Sometimes they don't have it at all. Some genetic disorders, they don't go through puberty. So there's many different things that you can see. There's also significant effects on medication. Sometimes they may be on growth hormones for different reasons. Sometimes their periods are light. Sometimes they don't have them at all. And we often find that if they have a stressful period of illness or they've had like scoliosis surgery, it may stop and it may not come back for a while. So there's a lot of variation in this from our typical population. Tools that we use, and I like to explain to my parents what the tools mean. We use typical CDC growth charts for the most part because they're an easy way to mathematically track our children. But one thing I want you to remember is the CDC growth charts were meant to be a screening tool for healthy American children. So if you're working with the different patient population, you need to try to see if there's a growth chart that's more appropriate for that patient. Sometimes when you're working with special needs, it's sometimes hard to do the measures. They can't stand. They may have contractions in their knees. They may have scoliosis. We had a statistician one time came to us and they said, why is it that the height is shrinking? Height doesn't shrink. It can if you have advancing scoliosis curve. So we see that often in our girls that have advancing scoliosis. Lack of head control. Some of them have braces. We have to take all the braces off before the measurements are done. And sometimes with our autistic kids, they have extreme aversion to being measured. They don't like the doctor's office. They will kick and scream and bite if you try to put them on a scale. So you have to try your best to get those measures, and I usually try as many ways as I can, but if I can't get them, then I just document that I made every effort to get those measures but weren't able to. And last but not least, there are also alternative ways to get measured. In the resources at the end, I included a good module if you're interested in learning how to do alternative measurements. There's a module at the end, so you can go and check that out. There are specialized growth charts for about 10 different syndromes out there. We did the Rett syndrome growth charts in 2012. That was a group effort of Rett teams across the United States. It took about 3 years to do those. And what we have to remember about growth charts is that you have to have a body of data so that you can make the charts out of. And you have to have the funding. So I would like to say that we may see more specialized growth charts now that we have computer applications and people who specialize in these areas, but the funding may not be there. So it's a lifelong journey, and that's part of your future. And again, there are a lot of growth charts from foreign countries. We are seeing a lot of children adopted from foreign countries now. I've seen several from China. I recently saw a child from Japan. A lot of kids being adopted from Haiti. So again, try to see if there are foreign growth charts so that you can chart them appropriately. There were lots of controversy about the specialized growth charts. Many of them are old. Many of them were done from small sample sizes. Many of them were done from chart reviews and not people actively measuring who were trained how to do it correctly. So if you're looking at an alternative chart, be sure that you feel like it's a good tool to be using. We were able to learn from these criticisms of some of the older growth charts. So when we did the Rett growth charts, we were able to circumvent some of those problems and try to make some of the best charts that were out there. And also, we used to do travel clinics. We would go to Oakland, Chicago, New Jersey, and Florida twice a year. And so we had a very representative number of health care across the country and Rett care across the country. And it really does vary. The kids out in California, innovative programs, healthy diets, where sometimes in our Northeastern, if they've had a really bad winter, a lot of those girls spend a lot of their winter time sick. So again, there's definitely disparities. There are definitely differences in the health that you see across the country. Again, I'd like to say there'll be more growth charts, we'll see. Skin fold measures, I routinely use skin fold measures. We are trained in how to use those. They make a difference. I can tell you if something changes, a tricep skin fold changes from a healthy 12 to an 8. So they're easy to use. There was a negative trend in 2003. There was a nutrition journal that came out to say, don't use your skin folds anymore because the equipment costs money, there's rapid turnover of personnel, they're not accurate. So there was a lot of things, but we are seeing a resurgence in the skin folds coming back, especially when we're talking about the malnutrition criteria that are out there now. And also, they're easy to do on kids. And so you have to prepare them. I call my calipers my tickle meter, and I play with them first before I do their skin fold measures. But again, they're pretty easy to do on kids, so it's a fertile ground for practice. We use PD tools for growth analysis. I'm sure all of you are familiar with this. This is a website that you can go to. It does many of your calculations that you need to do. Now, let's talk a little bit about mental health concerns that correlate with those nutrition problems that we just talked about. The top groups sort of all fit together: normal growth and feeding, parenting, anxiety, burnout, and multiple caregivers. A lot of young parents that we see today, they don't know what normal growth patterns are. And they always say, my child is terribly picky and they're not going to grow. But actually, children go through a slower period of growth where they're not going to be eating very well. And so picky eaters are a normal part of childhood for a lot of parents and for a lot of children, but you have to explain that to the parents. They get really anxious about it sometimes. I mean, almost to the point of just crying. I can't get my child to eat anything. So it can really be a problem. There's a lot of burnout with our kids that are on the autism spectrum. They can be extremely picky and have very limited food acceptance. And so the parents say, I know they need to eat, and so I give them what they want. So what you find sometimes is the parents will pack their breakfast and send it to school because they're afraid they won't eat at school. And so they end up with cereals, crackers, chips, and sometimes a breakfast bar, juice and water, which they pack in the morning, and that's what the kid eats all day long. Even at supper when they come home, they still have a choice of those limited amount of foods. So we have to break beyond that mold and move beyond that so that they can stay healthy. And with special needs, these children often have multiple caregivers who all have to be on the same page. And I'm sure Susan can tell you about this, but they have their parents, they have teachers, they have teachers' aides. Some of them come home to respite care. On the weekends, they have grandparents, they may have siblings home from college. So everybody needs to be on the same page with their health records, changes in their health status, and also what their feeding plan is. So very important. Another thing that we see is choking. Just back up a little bit. There was a very popular author back in the mid-2000s. Her name was Ellen Sater, and she talks about normal feeding patterns in kids. So we try to inform our parents about this. It's going to be erratic. There's going to be days they eat and days they don't. They are going to have normal, slower patterns of growth, so it's not as big a concern as sometimes we feel. You need to have some limits with them, but if you bribe them, they're going to eat less instead of the other way around. But the setting needs to be good. They need to make sure that you have good food for them, and also you can teach children about good nutrition. Again, there's our typical CDC growth charts, and in the BMI chart, you actually see this slump in growth where they go through that slower phase of growth. And so that's normal for them not to eat at that time and to not have a good appetite. Now, if we think about our special needs children, those normal precepts often do not apply. Many of them do not have a cognitive level where they can understand if you try to teach them about good nutrition. Sometimes the caregivers have a different concept of obesity than you do. We say they're obese or overweight, and the parents are going, no, they're not, they're just fine. So we see that a good bit. And then also we are trying to prepare our individuals for independent living, but there are some people who really don't need to be living independently. So parents need to plan appropriately for that. Often with special needs, they don't have a sense of satiety. They will eat until they throw up. So parents need to recognize that. Again, lots of medication side effects with increased appetite. It's very common that the foods are used as a reward, and we're going to talk about that in a few minutes because that has an early start, and we have to nip that in the bud and change that from the very beginning. And again, with autism spectrum disorder children, they can be very resistant to change, and even sometimes under the direction of the best feeding therapist, they may not change. Again, have variable activity levels. And I always ask that when my parents are in telling me about these picky eating habits, I say, well, what is your pediatrician saying? And usually they'll say, put the food on the table and they'll eat. Or let them get hungry and they'll eat. That is true of some children, but sometimes that's not true. They will not eat until the point that they are miserable. So you have to be able to distinguish between the two. Okay, we really push my plate. I think most of our parents get this, children get this. I know I agree with the Mediterranean diet. That's confusing for the majority of the parents that we work with. I'm still a strong believer that children, calcium and vitamin D is essential for growth those first 18 years. So I don't think that we should shortcut that. So we use my plate a lot and push my plate a lot and all of the different attachments that go along with that. Again, choking is a major problem. Parents really fear about that. I teach them about common choking hazards. Children under the age of 4 should stay away from dry meats, popcorn, hot dogs, grapes, peanut butter, nuts, raw vegetables, fish with bones, hard candy with nuts. We can do diet alterations. We can chop up food. We can moisten things. That's necessary. It's helpful. Sometimes kids can choke on utensils. I have a friend who was a special needs teacher, and they had disposable utensils at the lunch table, and the child was having a bad day. And so they were feeding this child, and the child bit down on the plastic spoon, and the bowl came off, and the child swallowed the bowl of the spoon. So definitely a big choking hazard. So fortunately, my friend the teacher, her adrenaline kicked in, and she stuck her fingers down the child's throat and pulled the spoon out. So we have to be careful that your utensils are durable, and you have to have them at school as well as have them in your purse. And I recommend CPR classes to all of our caregivers. They're available at the local Red Cross. They're also online at cprheart.org. And then also, I recently was traveling. I did a talk at Boston Children's Hospital to the Rett Syndrome team there. And this was in the lobby at BWI International Airport, a CPR kiosk where you could train yourself. There was a screen, and they also had the little chest plate there so you could practice your compressions while you waited for your delayed flight. So there are many ways that we can learn this these days. Let's talk a little bit about food aggression. This is not a new problem, this is an old problem. Food aggression is really when animals used to have to hunt and protect their food supply, where they would really fight over food. We see this with some of our special needs patients because food means so much to them that they will get aggressive if you don't give it to them. I know I was talking to one of the Children's Hospital psychiatrists, and they had a young man that was gaining a lot of weight, and so they'd made diet changes. And he was visiting with his counselor, and he punched her in the face during their counseling session because he associated her with why they took his pizza away. So what we have to do is we have to recognize when it's there. It can come out, try to figure out what the triggers are if you possibly can, and sometimes they need behavior intervention to eliminate or reduce this activity. Again, non-food rewards. It starts very early with potty training. People give the kids M&Ms, but with special needs children, because we have to often control their weight, they need a lot of other things that make them happy. And so I start my parents out very early on these things. You can do hand massage, you can brush their hair, you can brush their teeth, they can water the flowers, they can pet the animals. There's a lot of things that they can do to bring them happiness, and you need to start this early on. I had a patient in clinic a couple of weeks ago, a 10-year-old that liked his nails polished. He liked auburn orange and bright slimy green. So, I mean, his nails polished, so there are different things that you can do. So this is very important. Again, I'm not going to go through medications because Harriet did such a wonderful job yesterday. We're going to talk a little bit about tube feedings, and I wanted to say one thing that we did in our Rett Clinic is often the children would come in, and we watch their growth very careful in Rett Clinic. And we would look at them when they come in the door and we go, we're going to have our tube feeding talk today. But that really wasn't fair to the parents. So what we did is we did a tube feeding checklist now. So we sit down with the parents. If we feel that's necessary, we go through the checklist. We send it home with them so that they have time to think about that big decision that they are facing. So that's been a big help to us. We spend a lot of time in family education and working with metabolic disorders for the state of Alabama. it's very difficult to understand some of those diagnoses. And you can simplify it as much as you want to, but sometimes they can't understand, sometimes they can't remember. So we spend a lot of time in education. As Ms. Tarnpasta pointed out yesterday, you're really involved in their total care. The supplements they need, how those are provided. School diet orders are very important, and we do a lot of school diet orders through our office. But I always remember to praise my parents. If they're doing a good job, I tell them, because it makes a big difference to them. And sometimes I forget, but I try to tell them. And again, with children with special needs, usually at the age of 14, you prepare for transition. As they grow up, they will have to change physicians, they'll have to change specialists, they'll have to change or may change place of residence. So you really begin talking about transitions when you're in your early ages. And one other thing I wanted to talk about in the special needs environment is safety. This is a Children's of Alabama campaign that they had to bring patients in, and essentially what it was is that children do the darndest things and we have the care to help care for it. And you still see this around. Well, I laugh every time I see this picture because these are the kids that we see at Sparks. They crawl on the exam tables, they jump off the exam tables. They're told not to give them the medicine when they come. So they're crawling under the tables, running out of the room, turning the lights off and on. So you have to keep them safe. And this reminds me that in addition to your evaluation, safety is very important. Again, we have safe measuring environments, especially in the Rett Clinic. We have very nice equipment so that we can make sure that the girls are safe at all times. A little bit about case studies. This is an autism spectrum child, 9 years of age, referred for obesity and behavior management. This is what he'd eaten his whole life. Waffles, pancakes, fries, tater tots, grilled cheese, mini hamburgers, chips, corn chips, crackers, breads, and rolls. No dairy, fruits, or vegetables of any type. The family didn't eat together. Mom and dad ate at different times. The dad would fix the child's food and just put it down to the side and let him eat by himself. There was a great deal of stress in this family, so our team at Sparks, which is a multidisciplinary team, offered them family therapy, and they actually declined. They really wanted us to say that he needed to go to school in the summer because the school had refused to do summer services, but they really didn't want our help. And many of these other issues that we saw were pressing. This is, he was heavy. So again, in terms of nutrition diagnosis, many related to his poor diet, poor calcium, vitamin D intake, and obesity. This is another autism spectrum child. He was age 5, not in school because the parents didn't feel like he was ready for school. They thought he had Asperger's syndrome. He had no diagnosis of environmental allergies, speech delays, and sensory aversions, and his diet was sausage patties from one place, chicken nuggets from another place, Oreo cookies, and diet soda. That is all the child would eat. The parents both worked. He stayed with his grandparents during the day. And the dad even told me, I can tell when he's hungry, so I'll put him in the truck and we'll go for a ride and we'll go get chicken nuggets. So the parents really didn't realize that this was a poor food pattern. They had tried to change it. He wasn't going to change. And he also wouldn't take multivitamins. So we had to refer this child. Fortunately, he was already in occupational therapy. I called the local center where he was in the state of Alabama, and they said they had an occupational therapist that had some feeding therapy experience. So they were going to try to tackle this to their people that were local to their home. But this is not uncommon for us to see these type of diet patterns. Again, nutrition diagnosis was limited food acceptance and food allergies. A little bit about Rett syndrome. It is a neurodevelopmental disorder. Estimates of prevalence range from 10,000 to 1 in 23,000. Dr. Alan Percy is an international Rett syndrome specialist who works at University of Alabama, and he's been here for over 30 years. And his professional interest has been Rett syndrome for over 30 years. And so he'll tell you that the incidence is about 1 in 10,000. Variable clinical course. After doing the natural history study since 2005, we have lots of information about this disorder: genotype, phenotype, care. A lot of the individuals, the girls, have MECP2 mutations. They have found a number of mutations in the same gene. It's different in males in that males have your XY chromosome pattern. If they have a defective X, they can't compensate like sometimes the girls can. So it presents differently in males, and it's called males with MECP2 mutation. So it's a different disorder altogether, but we do see some. Often it's fatal with certain types of mutations in males. And then also the ones that have duplications have cognitive disabilities and respiratory problems and usually behavioral problems. Rett syndrome is different for everybody. And so you really have to recognize that when you work with them. There are worldwide efforts that are underway to find a cure. They were able to take the information from the natural history study, and they are now working with pharmaceutical companies to help with symptoms. They are also working on a gene repair type of therapy. It's in the very early infancy of working on gene repair. It's complicated with Rett syndrome in that the drug has to pass the blood-brain barrier. So it's going to be a while, but they have made an initial start and have a company that's trying to work on that at the present time. And again, we know that supportive care and aggressive therapy really improves the prognosis. How you diagnose Rett is typically they have a normal perinatal period. Usually they have a regression in function, so it's often mistaken as autism in the beginning. Normal head circumference, and then you see deceleration in head growth. And then also a hallmark is purposeful hand use and hand movements of some type. It's hard to take a picture of Rett girls without seeing with their hands, either clapping or ringing or tapping. And supportive criteria is abnormal breathing patterns, which include hyperventilation, breath holding, and puffing. They usually don't sleep very well. And then some other things that you see are many of them will develop seizures after the age of 2. Some of them develop scoliosis to the degree that they have to have surgery and have it corrected. Typically they have an abnormal gait, poor circulation in their hands and feet, and most of them are nonverbal. So a lot of them have communication devices when they come to visit you. And they also use them a lot in school. Some of them will develop seizures, and seizure medications, even the newer seizure medications, have a lot of nutritional side effects to them. They have to have a good neurologist. There are some girls that'll have spells that look like seizures, but they really aren't. They're more like Rett spells, neurological disturbances. So they don't respond to seizure medication, so you gotta have somebody that knows the difference. And interestingly enough, sometimes the seizures get worse during puberty with hormonal changes, and sometimes they may even change or go away when they get older. So lots of nutrition things that we see. Poor growth, in general, they stay small of stature. Oral motor problems, little self-feeding. Hyperventilation is a big one. That's kind of unique to Rett. Sometimes they hyperventilate so much that it's hard to feed them. We had a 5-year-old recently that lost 15 pounds in 4 months when she started hyperventilating. She was trying to figure out how to breathe and eat. All of her caregivers were trying to figure out how to feed her. And this little girl was only 5 years old, so a 15-pound weight loss is significant in this particular case. Many of them have low bone mineral density, again, scoliosis, drug-nutrient interactions, and we actually see and have a history of many of them will develop obesity and overweight when they get older. But now we know prevention is the key, and we start at an early age to try to do prevention with that. And so I'm going to skip this case study because I really want to turn the mic over to Susan Lee. Susan is mother to Alyssa Lee, and she had to go through the decision of placing a feeding tube. That's a really agonizing decision for a lot of the parents. And I think there's a lot of misconceptions about that. They think they can't eat anymore, and usually they can unless they're aspirating. There are a lot of really old misconceptions where they think if they're on a tube feeding, that means they're going to die. Also, it's not open surgery anymore, it's done by scope. So the picture is brighter, but the parents, it's a very hard decision for them. It's surgery. And so that's a number one decision. And I get tickled because I had a mother tell me one time, she said, I like to come in and see you But she said, it always makes me nervous when you weigh her in. And I have one mother that the child is thin, so we're really watching her and considering G-tube placement, and she won't even look at me when she comes in the clinic. Because she said, I know you're watching me, and I know you're thinking about that. So I always have to make sure that I catch her attention, that we have a discussion. So Susan is going to come up, and I'm going to ask her some questions. And she also has some pictures of her daughter, too, to share with you.
Okay, is this a mic also, or do I have to use that? Use that, okay. I'm gonna move around. I'm a teacher, I don't like mics, so I'm not gonna hold it really close. If you can't hear me, like wave in the back and I will speak up. Okay, good. So just really quickly, I just brought a few pictures. A lot of times I bring Alyssa with me, but,
There she is.
Okay. But obviously she's in school today, and so I did not bring her, plus she would want to interact with all of y'all instead of letting us talk. So this is Alyssa. She is 12 years old now. She was born in 2008, happy, healthy baby, youngest of 3. So I felt like I had this mother thing down pat. She was my easiest baby, never cried, ate great, nursed better than either of my other 2 boys. So really had no idea that anything was going on until a little bit later. These are a few things she loves. She loves her family. She loves her cousins. You see her 2 older brothers there. Disney World is her happy place. I don't know many little girls that's not their happy place, but she loves it. She loves horseback riding, being outside. It's a therapy, but that's probably her favorite therapy, obviously. She has lots of friends. We spend a lot of time with our Rett friends here. We also spend a lot of time with school friends. She's in a typical 4th grade classroom at Oak Mountain Intermediate School. She also has lots of church friends. There's her church friends. She's Girl Scouts. Girl Scouts is one of her big loves. She's been a Girl Scout for 5 years now. She's a Bronze Award Scout now, and top cookie seller in her troop. Girl Scouts, if she could do something Girl Scout related every day, she would. Loves camping, being outdoors, canoeing is her favorite, but we don't let Rett syndrome impede what we would normally do if she didn't have Rett syndrome. So scouting is important to our family, and so if she didn't have Rett, she would be a scout. Therefore, we are scouts. We tent camp, we camp in caves, we go canoeing. We don't let the things that she can't do impact the things that she can. Too many parents go, oh, well, my kid can't go hiking and rock climbing, and so they can't do scouts. Well, there's things she can't do, but we do the things she can. This is her Girl Talk speech group at United Ability. All of them have communication devices, and they have a great time together. We've recently started this Girl Talk speech group. They used to do it just during the summer, and we found out that their interactions and their willingness to interact was significantly more when they had other girls there, their age, that all communicated in the same way. So now we do it year-round, but that's our little group. And she loves dressing up in costumes. We do costumes. We do Halloween at our house big. So that's just a little introduction to Alyssa. And so Susie's going to kind of guide the conversation a little bit.
Okay. Like I said, the decision to place a feeding tube is a very difficult one for families. In my experience, I've only had 3 parents ask for a feeding tube. And so it just so happens that Susan and her family asked for one. And so she's going to tell you why they asked for one. And we also have what we call the juice story. So she's going to share that with you.
So a little bit about my background. I'm a special education teacher of 23 years. So that is my professional background. So as Alyssa grew and obviously had delays, started her regression, I knew things were not going well. But in my 23 years, a lot of what I did was feeding therapy with my children. I had kids with G-tubes. I had, seen really the progression of all of that. At one point, even though we were watching her weight, it got to the point where I realized Alyssa needed a feeding tube for a little bit of a different reason at that time, and that was her hydration. I watched closely, and even though feeding her was extremely tedious and time-consuming, we would sit at the table 45 minutes or an hour every meal because I knew how important it was that she get X number of calories in. I just could not get the fluids in that she needed. She had a little juice cup, and we would fill it at the beginning of the day, and at every meal, I would give her juice from that juice cup. During play times, I would give her juice from that juice cup. During any activity we did, I was pushing that juice. And at the end of the day, that juice cup that was this big, probably an 8-ounce juice cup, still had juice in it. And that was all the fluid she was getting every day. I started putting 2 and 2 together and realizing, okay, the fact that she's napping off and on all day long, and the fact that she's, they can't get blood draws at the hospital when we go for doctor's visits, was all really more of an issue with chronic dehydration. She was not getting enough fluids. So even though pushing the nutrition was hard, I was trying to do that, but there was no way I could get in the fluids that she needed. So I knew it was time for us to look at the feeding tube. Still wasn't an easy decision. As a mom, you feel like you should be able to feed your child. And as a special ed teacher, I had gotten 3 children off of feeding tubes by doing food therapy, and they no longer needed them, and yet I couldn't feed my own child. So even though I had to ask for one, it wasn't an easy decision, but it was one that was necessary. And now that she has seizure medications and and all of that going on, it's a godsend. But
what was the rest of the family's reaction?
So as a mom and a wife, I know how to handle my husband. He did not know when I ordered the wheelchair. He did not know when I started her in certain therapies. I had to feed that information slowly. So I did not necessarily go in and say, hey, it's time for a feeding tube. But I started pointing out things throughout the day. I'm like, hey, do you notice how she's sleeping so much? Or, hey, do you notice how she's not even drinking 8 ounces of juice in a day? Do you notice how she's just not, that we can never get blood draws? And so I started feeding those facts as we prepared. And then finally, I did say, look, I know that it won't be easy, but here's really the option that I think we need to go with. I have a very supportive husband. He trusts what I say, especially in the area of medical and educational with the kids. So he was on board reluctantly, and even, and I'll have to say, after the surgery, she had a rough couple of weeks, and several times he and I would go, what did we do? We brought our relatively healthy, she wasn't sick and in the hospital all the time, relatively healthy child, and we did this surgery, and now she's crying and she's uncomfortable, and we have all this equipment in her bedroom. So what exactly did we just do, and was it the right choice? 6 months down the road, and from there on, I tell parents that we should have done it sooner. And if you poll a large representation of people, parents that have had to make the same choice, my experience is a large majority, 80 to 90%, will say, I wish I had done it sooner. But in the moment, that doesn't make any difference.
What did her therapist think?
Her therapists were all on board, especially once we were getting the appropriate nutrition, the appropriate fluids. She was awake. They didn't have to keep waking her up for therapy. She was stronger. She was more motivated. She was more just totally engaged with everything. So they totally agreed. It was, at first they went, why? Because she was eating by mouth. But once they saw the difference in her and her overall nutrition, they were very supportive.
Are there any negatives about her feeding tube at this time?
Negatives. It depends on what you call a negative. There's negatives to everything that we do. We choose to smile through the negatives and keep on going. There are certain activities we have to be more careful about. Horseback riding, she wears a support vest. If that vest gets up under the edge, then we pop out our feeding tube. Packing to go on a trip is a lot harder. You have to pack your pumps, you have to pack your bags, pack your formula, pack your syringes, pack your extensions, all those different things. So those, it's just, I wouldn't say negative because of the amount of benefit that we've gotten from it. Harder, yes. Have to think through things, yes. especially your parents that get frazzled at the drop of a hat, that every little change or every little thing that adds to just the difficulties of parenting, that it's going to be harder. So I don't think the transition was as difficult for me as maybe other families that I've kind of helped through the process, but it does increase what you have to think about.
And Susan, at this time, is she on a commercial feeding or a blended feeding?
Do you want the real answer, or do you want
The real
scripted
answer. The real
Okay,
answer.
and I say that because you learn as a special needs parent, you have to play the game. And the game is insurance will not pay for your formula or your tubes or your extensions or your syringes if you're not on primary tube feeds.
Right.
That being said, if the tube feeding company, the pharmacy calls me and says, how many bottles of Kate Farms do you need this month? If I say anything less than 30, then insurance will deny it and I won't get her extensions or her tube feeds, her tube extensions, her syringes, her replacement feeding tubes. I won't get any of that. So you say, oh, we need 30 bottles of Kate Farms, even if she's in a really good period right now where she's not having to have nutritional supplement. So that is the scripted answer that special needs parents have to tell the pharmacies, which we hate because none of us want to waste money. None of us want to waste formula. None of us want to waste supplies. But at the same time, I can't afford 4 little extension tubes a month, hundreds and hundreds of dollars. I can't afford all of that. I can't afford a new button is, I don't even know how much hospitals charge for those, $600, $800. So the scripted answer is, yes, my child gets, 1 bottle a day or whatever you and your doctor figure out. The real answer at the moment, Alyssa most days does not need supplemental nutrition. She still needs all of her fluids and all of her medications by G2. She's extremely bright. She knows if you put any medication, any nutritional supplement into her food, we tried every one of them and she noticed and would quit eating those foods. So right now we run a big bag of water overnight. She gets another 8 ounces of milk during the day. She gets another supplement of water with her breakfast and dinner. And then all of she's on 9 or 10 different medications right now, and all of those go through her feeding tube as well.
Okay. I think we're going to end there because we're going over time.